I think I've changed the. Would like to thank Dr. Banerjee, Dr. Rahman, Dr. Nurul Islam, my friend Dr. Majumdar, and all my friends in the Bangladesh Cardiac Society for their kind invitation. I've slightly changed the title. Often, many of my juniors come and ask, have I done something wrong? Some answers to questions your juniors may ask. And that's the way I will go by, and I will take on mainly case reports. First is a case of mitral regurgitation. This is a patient with mitral regurgitation where the person who was doing the echocardiogram was so apologetic and came and told me, sir, the regurgitant velocity is 7.52 meters per second. How do I account for this velocity? The brachial blood pressure which I took is only 160. The LA pressure is 26 plus LA pressure is so high. How to explain? Let us look at what was happening in the various cardiac chambers and valves. When we looked at the mitral regurgitation, if you look at it is fairly early, not bad, and mid to late systolic. Not only that, look at the aortic valve. It looked very odd. Aortic valve showed early systolic closure and lot of undulations. These undulations of the aortic valve leaflet indicates that leaflets are absolutely normal. A thickened aortic valve will not produce these undulations. So valve leaflet as it is normal. And then we looked at the 2D echo, and it's very obvious that this patient, in addition to having mitral regurgitation, has a hypertrophic cardiomyopathy. The basal septum is bulging. The anterior leaf, the mitral valve is touching the systolic anterior movement of the mitral valve, and the diagnosis is obvious. This is a hypertrophic cardiomyopathy with mitral regurgitation. It is the systolic anterior movement, which a torrential flow through the aortic valve produces this aortic valve leaflet flutter, early systolic closure, and the flutter by which aortic valve remain partially closed throughout the rest of the system. But the velocity, how did the velocity of 7.52 come? Commonly, the velocity becomes high when you have aortic stenosis with mitral regurgitation. Here we don't know. We know that there is no valvular stenosis, but there is some element of subvalvular stenosis. There is a SAM, mid-systolic alveolar obstruction, high pressure in the LV, mitral opening in systole, and high velocity MR. I had to demonstrate it. You had to demonstrate to your juniors that these things are happening one by one in the same patient. You look at this, what is happening. This is systolic anterior movement of the mitral valve, systolic anterior movement of the mitral valve, and you find there's a partial closure of the aortic valve also. These things are happening in systole. Remember, mitral valve is supposed to remain completely closed. Aortic valve is supposed to remain completely open. In systole itself, you find there is a partial opening of the mitral valve and partial closure of the aortic valve because of the hypertrophic cardiomyopathy and the peculiar hemodynamics. Is that all? Is the question. Look at this mitral valve very carefully. The pathology is not stops at the level of the subvalvular structures. You look at the aortic valve, look at the mitral valve. Mitral valve looks thick and boggy, and mitral valve is relapsing into the left atrium, look at the huge mitral valve prolapse of both the leaflets. And this myxomatous disease, the mitral valve, with mitral prolapse of AML and PML, with MR, is the cause that the MR was long stay throughout the systole, most of systole. And otherwise, MR would have happened only in mid to late systole, only probably in late systole. So this patient had systolic anterior movement of the LVOT producing obstruction. At the same time, there is mitral regurgitation happening. Please note the mid-systolic opening of the mitral valve, mid-systolic opening of the mitral valve, in mid-systolic closure of the aortic valve, in the QD and MOD echo. We could demonstrate every one of these phenomena occurring in the stop frame analysis. Hypertrophic cardiomyopathy, asymmetric subtle hypertrophy, systolic anterior movement, LVOT obstruction, premature closure of the aortic valve, and mitral regurgitation as well. Myxomatous disease of the mitral valve with AML and PML prolapse producing mitral regurgitation with a very high velocity. So everybody was convinced, and that's it. Next is the case of ventricular septal defect, not the common variety. This is a post-traumatic ventricular septal defect. It's a post-traumatic ventricular septal defect. The car collided against a tree. He had a lot of head injury, taken to the hospital, put on a ventilator, assigned with sedation, muscle relaxant, heart rate tachycardia, little high blood pressure, no cardiomegaly, heart sounds normal, CV is normal, polytrauma, CT head shoulders, subrecurrent hemorrhage, diffuse cerebral edema, echo study was normal heart. And next 2 weeks, he improved to be mobilized to bedside chair with tracheostomy and peg feeding, and we thought that was the end of it. ECG was normal, chest X-ray was normal, echo was normal. But on the 12th hospital day, clinical examination, he developed a pansystolic murmur in the left side of the body. Murmur appeared to spill over the diastole. Chest structure showed pulmonary edema, and he required more oxygen for maintaining the oxygen saturation. Everything changed on the 12th hospital day. Tachycardia, blood pressure fell to 90/60, bilateral crepitations over the lung fields. And look at what has happened to the septum. There's a large area of the septum has given way. Large area of the septum has given way. And through that, there is a left to right shunt directly into the outflow tract of the right ventricle. Large left right shunt to the outflow tract of the right ventricle. And look at the velocity profile. This is the classical velocity profile of the VSD. But on second look, you think there is something odd with this velocity profile, and that is what has alarmed my colleagues. You find this is systole. This is systole, end of systole. This left to right shunt is occurring in late diastole as well as early diastole. This is a historical diastolic left to right shunt. Can you hear me? This is a systolic diastolic left to right shunt. Systolic diastolic left to right shunt. And what does this mean hemodynamically? What does this mean hemodynamically? The ventricular septal defect was a fairly large one. Large part of the septum has given way. VSD with left to right shunt. Why is the left right shunt continuing diastole? This is because this is radically different from congenital VSD. In congenital VSD, RV and LV diastolic pressures remain normal. Cardiac failure is a terminal event. Till the time it will not happen. But here is a traumatic VSD. There is an acute left ventricular damage to the left-right shunt. Left and right ventricular damage to the left-right shunt. Sudden shunt, raising the LVEDP, producing diastolic left to right shunt. And that is the mechanism that we have been observing in the Doppler velocity profile. This trauma of the left ventricle could well be demonstrated by strain pattern. Minus 7.2 was the global strain. So significantly damaged left ventricle. acute trauma and sudden left to right swap. It took a long time for the left ventricle to recover. This is 3 months after surgery. It was only 6 to 8 months after surgery, left ventricle became nearly normal. And this is the pattern of acute traumatic ventricular septal defect. RV and LV takes long time to recover. Yet another patient. This patient had mitral tricuspid valve disease and significant tricuspid regurgitation. Question was, can you diagnose tricuspid stenosis in the presence of significant tricuspid regurgitation? This was the question that was asked to me. Patient mitral stenosis with mitral regurgitation, as you may see here, and mitral valve was 1.1 square centimeters. This is the right side, and we find there is quite a bit of tricuspid regurgitation, but there is a turbulent flow across the tricuspid valve in diastole indicating there could be a tricuspid regurgitation, tricuspid stenosis. Is it the turbulent flow by the tricuspid regurgitation was the main question. On imaging tricuspid valve very carefully, looking at the septal, the anterior, the posterior, and the anterior leaflet, you could see diastolic doming of the tricuspid valve. Diastolic doming is the anatomical synchron of tricuspid stenosis. How to demonstrate it? Demonstrating is looking at tricuspid gradients. But in severe tricuspid regurgitation, you could have a diastolic gradient occurring because of torrential flow. But remember, that occurs mostly in early diastole. When you find there is a end-diastolic gradient, there's an end-diastolic gradient, you find that at the end diastole, there is a obstruction. Tricuspid regurgitation produces a patulous valve through which the whole blood will flow into the right ventricle in diastole, mostly in early diastole. There cannot be a late systolic gradient as you may find here. Late systolic gradient as you may find here. Not only that, the atrium was vigorously contracting, as is evidenced by a diastolic flow into the pulmonary, across the pulmonary valve. It was forcing open the pulmonary valve with a diastolic flow into the pulmonary valve. The atrium was so strong at the end of diastole, so strong at the end of diastole. So much was left behind in the left atrium that it contracted so well that it forced open the pulmonary valve. So much of pressure wave was created, and this pressure was reflected back in the IVC also. You could see the A wave. You could see the A wave in the IVC indicating a strong atrial contraction. These are our patients with a lot of diuretics, and that's why the IVC is not dilated. The atrial systolic reversal was very well delineated in the hepatic venous flow also. So you have multiple signs to suspect tricuspid stenosis. End-diastolic gradient, and atrial systolic flow in the pulmonary valve demonstrated by color and pulse Doppler, and atrial systolic reversal in the hepatic veins. So these are the signs by which you diagnose tricuspid stenosis. Tricuspid stenosis in a patient with significant tricuspid regurgitation. These are organic tricuspid disease, secondary to rheumatic fever, and please look for tricuspid stenosis very carefully in anyone who has significant thickness of the tricuspid valve. And you can diagnose tricuspid stenosis by these various signs. The next patient is a poster PDA presenting with cyanosis. The question was, how did she develop cyanosis? History of PDA closure at the age of 4 years, 1983. She stand up in 2017 for a ventral hernia repair. Recently had effort dyspnea of grade 2, psychiatric problems and medical management, postlateral thoracotomy scar on exam, clinically normal, ECG and chest x-rays were normal, clinical path results were normal, oxygen saturation was 19%, excellent. Chest x-ray was normal, and echocardiogram was normal, and there is some pulmonary regurgitation. Unfortunately, it was not profiled, so we don't know about the pulmonary diastolic pressure, but the left heart was normal, And the peer pressure preoperatively was 51 millimeters of mercury. 51 millimeters of mercury preoperatively. She was cleared for surgery. We always respect ventral hernia repair because post-operatively, patient may have a lot of problems because the abdominal band. Next day after surgery, patient was doing fine during the morning rounds. By afternoon, tachycardia was noticed. CVS was found to be normal. By evening, patient complained of dyspnea and chest discomfort, clinically diffuse lung signs, and surprisingly, arterial saturation was 88%. Chest X-ray showed right basal consolidation. CT pulmonary angiogram was normal. CT lung showed right lower lobe collapse. Small right pleural effusion. Patient was moved to medical intensive care room and put on oxygen. Right lower lobe collapse in the skygram. And the echocardiogram was radically different. We find dilated right ventricle, flattening of the interventricular septum with a reverse D. And picture was one of severe pulmonary hypertension on echocardiogram. Look at the right ventricle, which is markedly dilated and probably a little hyperdynamic. Left side of the heart was normal. And the peer pressure from earlier 51 went up to 83 millimeters of mercury on the day after surgery. This peer pressure was associated with a marked arterial desaturation. 80% arterial saturation on 6 liters of oxygen. On 6 liters of oxygen. And she was obviously markedly dyspneic. Doppler showed primary pulmonary hypertension. So the TAPSE was normal, RV function was normal. And pulmonary angiogram was also normal, but right lower lobe collapse, consolidation was a finding on CT. The peer pressure still went up to 95 millimeters of mercury, and this was a finding. And by about the fifth post-op day, the peer pressure came down to 71, and she was slowly weaned off oxygen. Arterial oxygen on room air was 92. She was still desaturating. Why should a patient desaturate? And this desaturation is seen everywhere, unlike a PDA reopening and producing a shunt to the PDA. Lower limb, upper limb, it was all the same. Why should she desaturate? This was the main question they were asking. Why should there be 92%? We thought we have to do something to demonstrate the desaturation. And we thought we will do a saline contrast echo. Saline contrast is still the right side of the heart. But you can see it forcing open the foraminal valve and producing a right to left shunt. From acute pulmonary hypertension, acute right atrial hypertension, forcing open the foraminal valve and the right to left shunt across the foraminal valve, producing cyanosis. The cyanosis was far more worse when the peer pressure was 95. It came down slowly when the lung recovered. And this kind of phenomena is very common in patients with patent ductus arteriosus. Patent ductus arteriosus may have a hyperreactive pulmonary vascularity. Such pulmonary vascularity may react to a collapse consolidation and raise the blood pressure to very high levels, raising the right side of pressure, producing a right left shunt at the atrial level. Persistent arterial desaturation. She's slowly becoming asymptomatic and discharged. In about 6 months' time, she was absolutely normal with normal saturation and normal activity. So this is a very mysterious situation where we were finding it difficult to explain. 65-year-old motor mechanic, recurrent history of fatigue and dyspnea, nausea and vomiting 1 week, multiple hospitalizations for cardiac failure in the last 2 years, heart rate 68 per minute, BP 130/80, AVP elevated, mild cardiomegaly, normal heart sounds, no murmurs. He was on numerous drugs, digoxin, beta blockers, diuretics, statins, lab investigation, routine workup was normal, mild cardiomegaly, ECG showed LVH with strain. Apical views today, lazy left ventricle, dilate. It is slow in everything. A lazy left ventricle, apical view. And when we looked at the tissue velocity, that's the time my colleague Ryan coming to me. Sir, this tissue velocity looks grossly abnormal. Tissue velocity, this is the S wave. This is the mitral closure time. This is the mitral opening time. Here is the isometric contraction time. This is the isometric relaxation time. Normal isometric contraction time is 50 milliseconds. Here it was 175 milliseconds. Normal isometric relaxation time is 100 milliseconds. Here it is 210 milliseconds. Far beyond anything you can imagine. S waves are so small, 3 centimeters, normally more than 6. All the measurements, systolic, diastolic, as well as isometric phases, are prolonged beyond imagination. This is how you measure the myocardial performance index, mitral closure to mitral opening, aortic valve opening to aortic valve closure. This is A, this is B. Myocardial performance index, A minus B divided B, will give you myocardial performance index. My colleagues found that the myocardial performance index was 1.38. Normal is less than 0.39. 0.39. 1.38, far beyond their imagination. A myocardial performance index or T index more than 1.4 was independent prognostic factor for death or emergency heart transplant during 2 years follow-up and had more predictive power than EF or NIHA class. So this was a very, very drastic situation. And this particular patient with what looks like a dilated cardiomyopathy had a very prolonged myocardial performance index. You can see, you saw that situation. Here is a patient with dilated myopathy without any wall thinning. There is small pericardial effusion. There is no wall thinning at all. And apical view showed earlier. But there are many other signs when you look into detail. This is a QRS complex. Mitral valve closed 90 milliseconds before the QRS complex. Mitral closed 90 milliseconds before the QRS complex. So there's a premature closure of the mitral valve. Look at the dimensions. 80 millimeters of diastolic dimension and 60 millimeters in systolic dimension. This is a dilated cardiomyopathy, but without any muscle thickening, muscles are retained. And the 3D ejection fraction is 31%. They have very poor ejection fraction. L waves across the mitral valve, L waves across the mitral and tricuspid valve, indicating congestive heart failure. There is something more. We looked at the mitral regurgitation. These mitral regurgitation started long before the QRS complex. It's a dazzling mitral regurgitation. Long before the QRS complex, mitral regurgitation started. And this dazzling mitral regurgitation could be delineated even in continuous wave Doppler echocardiography. There's a dazzling mitral regurgitation, evidence in continuous wave Doppler echocardiography. Patients, IVC was normal because of too much of diuretic therapy and we were withdrawing. And strain pattern.
2 minutes left to finish the talk.
Madam?
2 minutes left to finish the talk.
I'm finishing. It's only a 24 and a half minute talk.
No problem.
I will give 25 minutes, 24 and a half minutes talk. The strain was markedly reduced, and you find unusual things in the strain. You find a lot of post-systolic strain. What's the use of post-systolic strain? Picosystole, contracting in diastole. Contracting in diastole is a wasteful expenditure. What's the diagnosis? Dilated cardiac chambers, poor contractility, premature closure of the mitral valve, diastolic mitral regurgitation, elevation in mitral diastolic flow pattern, pericardial effusion, prolonged isometric features, myocardial performance index, grossly abnormal. This was due to simple hypothyroidism. All the features of hypothyroidism were there when you look back. TSH is markedly high, T4 is very low, and cholesterol is very high. And this patient is put on, Eltroxin 25 microgram for 5 days, for 5 days, and continued to 75. He was discharged asymptomatic and walking for 15 minutes twice daily without symptoms. I was trying to present very odd signs in echocardiography, which my colleagues brought to me, and we had to complete the study and give them a diagnosis. These are areas where you can go wrong if you do not direct them correctly in the correct direction. Thank you, ladies and gentlemen. This 24-minute talk, I presented 2 cases which showed that how to proceed correctly to avoid pitfalls.